Welcome to the Reflection Room. We have Dr. Griffith back with us today. He may look familiar. We've had him a couple times on. He is a board certified psychiatrist who specializes in TMS therapy. And we actually posted a Insta story asking our followers for questions for Dr. Griffith that he could answer some frequently asked questions or thoughts that people have had about psychiatry or medication related to psychiatric medication. So we're really excited for these questions that you guys have asked, and they come up in therapy a lot, and some of them are questions I have myself. So I'm really excited to hear about what he has to say on this. And thank you for being here, Dr. Griffith.
Well, thanks for having me again. I really enjoy spending time in this manner with you guys, and it's exciting. I hope people get to watch the podcast that you all provide because I know that it's an informative media. So thank you.
Thank you.
Thanks. All right. Well, how about we get into this? So this one you had talked about before, the topic of ADHD. The first question is, why are so many people suddenly getting ADHD diagnoses as adults? Is this overdiagnosis or just better awareness?
Great question. I think it's multifactorial, the answer. Number one, it's when I first started practicing psychiatry after my residency training at the Cleveland Clinic. At that time, the pharmaceutical companies had obtained FDA approvals for stimulants, Ritalin first and then Adderall later. And the studies were essentially for the younger population, kids and teenagers. So that was coming out of the gate, how stimulants were used in the younger population. Adderall then obtained approval for adult usage. And so then the pharmaceutical companies that made those agents, whether they were brand or generic, were starting to call on the clinicians who treated adults. So you saw a rise in the number of stimulant prescriptions from kids and teens and then into adults. And then what happened is the internet, and on the internet were posted lots of self-assessment tests that would help people understand what ADHD. ADD is just a distractibility. The ADHD includes hyperactivity, and they can come in either flavor. And so the internet really expanded awareness of the public of ADD and ADHD. So you had more and more kids being diagnosed just because the family members, the parents would understand and take the kid to the child psychiatrist or the pediatrician and say, my kid's not paying attention. I think the schools were very well educated, and some of the problem students, the teachers, oh gosh, this kid fidgets. He can't sit still. He can't pay attention. They would contact the parents and they would refer to resources to get treatment. So another factor was COVID. During COVID, people were stuck at home and they were on their computers a lot more. And what happened was all these teledocs, all these companies that would provide online diagnosing, and that was a huge escalation in the number of cases of ADD and ADHD because we're all sitting at home bored, we're watching Netflix or going online. And so there was such a huge increase in the number of patients. So there's a combination of factors. Clinicians are more educated in diagnosing it earlier. The public, the parents in particular, and adults are more aware of it being an entity that can be treated with medication easily. That's a real complicated answer, but there you have it.
Yeah, I know that was really helpful. And I think in our field, oftentimes that's typically the answer anyways, where it's like there could be a number of factors that are kind of like, potentially causing this or impacting whatever it is that we're seeing. I do have a follow-up question. So I was not many people know this, but I was a children and family therapist for many years before I transitioned and started working with predominantly women and couples. And I would have parents come into my office often and they would say, I think my child has ADHD. And a lot of times I would have to have the conversation with them about what is just normal childlike behavior for just appropriate, age behavior for their children for that specific age range. So I guess what's sometimes a lot of our clients will enter our offices and want to know, how do I know if it's this or that? Or how do I know if it's, a diagnosis or just like typical normal behavior. So in this specific case, when it comes to ADHD, I guess specifically with, children, but how would a parent know if it's like appropriate age behavior or maybe something that might be a little bit more concerning where they might have to come into, let's say, your office?
That's a tough one. How does a parent know if their child has ADD or ADHD? Unless the hyperactivity part is present, it's such a hard disorder to understand and perceive, for lay people. And gosh, kids can be sent to get formalized testing with a psychologist, and it may cost a few $100s, $1,000, but that formalized testing with a trained psychologist can be very helpful. We have an instrument that we use in our practice, and it's online. It's more for adults, but it requires 30 minutes of attention to a computer screen, and the software is able to pick up fidgetiness and kind of distractibility in answering these questions. And it's question after question, and you have to remember the answer to the prior question for the next question to answer that properly. So you have this retention, you have to be focused. So that helps us diagnose it. I personally, as a psychiatrist, I tend to protect the budgets of patients and families, and I don't make them go get the $1,000 testing with psychologists. I do a kind of a thorough exam and history taking, and I go based upon that. I do a pretty good job, and then you can prescribe the stimulant in a low dose. And the beauty of stimulants is that if they'll work in 30 minutes. So a person takes a dose of Adderall, and if it's a strong enough dose, but obviously not overly strong because it's just a starting medication for a patient, in 30 minutes, they'll feel more calm, more focused, they'll be more motivated to complete their tasks. So part of the diagnostic work that I do is just providing the prescription with a follow-up visit pretty quickly to see how the medication worked. And Adderall is like 90% of the time, if someone has ADD or ADHD, it'll be effective for them in some way. So here my wife and I, like with our son, he felt tortured to do homework, but we got him on Ritalin finally when he was like 12, 13 years old, and then he got straight A's thereafter. It was a phenomenal turnaround.
I think that's so funny how, sometimes I think that clients or just the outside community will sometimes look at us within the mental health field and, they'll think, oh, you guys must have your lives together, or life must be perfect, or your relationships must be perfect. And, and I think that speaks to, and it's like, even sometimes things right under those are the things sometimes we miss, or the things right under our nose oftentimes, right? Or the things that we see on a daily basis so consistently, and those are the things that we happen to miss sometimes, the things with our family or loved ones.
I think it would be important for parents to try to have some awareness of how their kid is performing in school in particular, and around their peer group during playtimes, and at home, like doing homework and assignments or chores. And maybe if parents can become familiar with what ADD is, ADHD, and how it presents in so many different ways, that's helpful. And then also it's nice if parents, when their kids are young anyway, to be networked with the teacher, to get feedback from the teacher. How does their child compare to the norm of students, in the teacher's history and in that particular classroom? And I think the teachers are very gifted, very experienced at picking out a kid who has trouble focusing, completing assignments, or difficulty sitting still. So, you can't take a blood test for it. It's observation and observation of behavior over, a continuum of time.
Yeah, no, I think that's making sure to talk to a lot of the adults that your child is interacting with and kind of seeing how they're presenting in different settings. I think that's huge. You highlighted something a few minutes ago. You said typically within like 30 minutes, the medication will kick in and they'll kind of notice a change. And so that kind of leads us to a second question, right, Hannah, that one of our viewers was really interested in, and they wanted to know, how long does it actually take to know if a psychiatric medication is actually working? So with ADHD medications, it seems like it's pretty instantaneously. You'll know whether or not that's the case. How about with some of these other medications that fall outside of the ADHD umbrella? What's the answer for that?
Yeah, and let me just go back to ADHD real quick. So the stimulants, the controlled substances that are used to treat it, they work very quickly. But then there's some non-controlled substances that kind of
Hmm.
work on the norepinephrine dopamine system, and
Oh.
they're almost like antidepressants, but they're approved by the FDA for treating ADD, ADHD. One of them is called Strattera, atomoxetine. Another one is called Qelbree. Those will take longer. So you have to titrate the dose upward, and it may take 2 to 6 weeks to really find out if they're helpful. But the stimulants instantly acting, a day
Okay.
or two, 30 minutes even. So, okay, let's go outside of ADD, ADHD. Gosh, differentials of response. Let me talk about anxiety first, especially panic attacks or someone who's like a generalized anxiety disorder. And for panic attacks, that is an episode of like adrenaline, heart racing, short of breath, sweaty, shaky, kind of a sense of mental cloudiness, confusion, almost a feeling of dread, like I'm gonna die. Panic disorder, people will often call 911 or go to the ER, and they'll get a cardiac workup because their heart's racing just to make sure they're not having an arrhythmia or heart attack. Now, in psychiatry, we use a lot of benzodiazepines for panic disorder: Xanax, Ativan, Klonopin, Valium. Those medications, based upon how often, well, let me just say, those medications can also work in 30 minutes. I have a lot of patients where we don't want them to take Xanax every day, like 3 times a day, but they'll have Xanax in their pocket or their purse. And when a panic attack starts happening, they can take a Xanax, and in 30 minutes, the Xanax can really overcome that particular episode of a panic attack. And now Ativan is quick acting like Xanax. Klonopin takes about twice as long to act as Xanax. But the beauty of Klonopin is that because it takes a little longer to act, it also lasts longer than Xanax and Ativan. So the problem with Xanax and Ativan, yeah, they work fast, but they wear off fast. So then people get used to taking them because Xanax and Ativan and Klonopin and Valium, they're like alcohol in a pill. And so people start going through withdrawal in between doses of Xanax and Ativan, which promotes taking it more frequently. So it's kind of like a dog chasing its tail sometimes. And so it's really nice to be able to have people just take Xanax or Ativan only when they need it, but not every day, all day. Valium is in the benzodiazepine family, and it doesn't work quickly, because Valium, the molecule goes through the liver as it goes through the bloodstream. And every time it goes through the liver, it gets metabolized and changed by the liver. And it has like actually 5 versions of it, metabolites we call them. So Valium has like 5 different versions that each time it goes through the liver, it gets changed into the next version. That version also helps for anxiety. So it's extremely long lasting, like for days perhaps, but it's also not quick onset. So if you have someone who's driving over the Howard Franklin Bridge and they're prone to panic and they need to take it for their panic attack, Valium's not the solution. Xanax would be. So, okay, that's the answer for benzodiazepines, how quickly they act. Antidepressants, it depends on the individual. We, in psychiatry, we generally feel that it takes between 2 to 6 weeks to really kick in. So the antidepressants, especially the ones that are serotonin based, they don't work on a part of the brain that immediately treats ADD or panic. It works in a deeper part of the brain that has to go through some dynamic changes over time until the happy hormones or neurotransmitters are enhanced: serotonin, norepinephrine, dopamine. And that generally takes 2 to 6 weeks. That being said, sometimes we start off with a certain dose of an antidepressant for a patient and they run into side effects, so we have to stay at a low dose for a while. That may not be strong enough to treat their overall symptoms. So over time, we may, as they get used to the medicine side effects, we can increase the dose. So that could take months, perhaps, 2 to 3 months. I've had some patients who I prescribed serotonin medication to, and they say even the first dose gave them a feeling of happiness and calmness.
I was going to ask you about that. There are some
Yeah,
clients
Yeah.
I've heard that have said they've instantly felt a change, but I've
right.
also heard that typically it takes about like 4 to 6 weeks. So I was
Yes.
going to ask you, is that really happening, or is that more so like a placebo effect almost for these clients?
It really happens in some people. I would say those are the lucky people, because the patient is giving you an immediate declaration that this is a good medication for my symptoms. And then over time, you see if that initial dose is strong enough to maintain control over the symptoms. And then you have to look out over time for evil side effects. Like maybe they get tired on it, or maybe they get nauseated on it, or maybe they start gaining weight or losing weight, or maybe, okay. So, side effects are like a big part of prescribing antidepressants. So, it's some people with antidepressants, they're lucky and they respond early, and other people, it takes a while. So it's a difficult answer. A lot of variability.
Yeah, well, actually, our next question kind of loops back to something you said earlier about the ADHD medication, which you said Adderall was originally made for kids and then made for adults, which I feel like is not that common. But the next question was, how do psychiatric medications work differently in teenagers versus adults?
Let me talk about kids versus adults, kids and teens. So our youth, the kids who are, I don't know, like grade school age, they really their livers are hypermetabolic, and they really break down medications quickly. And so sometimes you actually have to use pretty hefty doses in kids because of that. Teenagers are, gosh, they go through so many hormonal changes. I mean, the body is in flux. And I've always felt that teenagers, they're kind of, each one is somewhat unique, and you have to really pay attention to, like, for instance, when I prescribe Zoloft, which is an antidepressant, when I give it to teenagers, most of them gain significant weight. But when I give it to adults, they don't gain weight typically. I mean, some do, but nothing like the teenagers. So there's metabolic differences as we age in the body. My rule of thumb is to start with low doses, because my patients, I don't work at the hospital. I don't have 24/7 nursing care to monitor how people are doing. They come to me, they see me, they fill their prescription at the pharmacy, then they go home, and the next day maybe they're going to school or work. So I have to allow them to remain functional, and I cannot be overly aggressive with dosing. I just do that out of respect to people who are trying a new medication. The other thing is, I believe that a medication in the beginning should be a gentle handshake and not a bear hug with a high
I
dose.
like that.
Yeah.
Yeah.
Now, obviously, if someone's acutely suicidal or acutely psychotic or acutely agitated, I've got to use a big dose. But generally speaking, people aren't that way. They need help with medication. And I'm always starting a low dose, like 2 to 4 days, and then a whole pill thereafter. Or if it's a capsule and they can't split it, maybe every other day they take it for 2 to 4 days, and then they start everyday dosing. And I'm usually writing for low doses. And then over the course of, let's say, 4 to 10 days, I'll increase the dose to more of a, like the low end of the therapeutic dosing. And that is a very effective way to respect patients, allow them to function and not, disrupt their life. And then I tell them, look, it requires a little bit of patience. You're not going to get better so quickly. But believe me, this is a chemical in your body. Let's give it a chance to see if your body likes it or not. And then we're talking about how it's different during stages of, or age differences through the life cycle. The geriatric patients, it's very complicated to medicate them with psychiatric meds because A, they're on other meds that interfere with the psych meds and vice versa. And secondly, they're more sensitive, generally speaking. They may be more tired, or they may become more foggy in the mind and forgetful. You cannot make them tired or clumsy so that they fall and fracture a hip. So geriatrics are very challenging to medicate because of other medications, other medical problems. Their bodies are just fragile in general. So that's kind of an overview of different ages within the life cycle.
Yeah, that was really
Yeah.
helpful. And I just want to highlight something too, just for our audience. I think it's you brought up a good point about with the geriatric population, that they're taking other medications, but then also just in general, I had a similar experience not a few years back where it wasn't with a psychiatric medication, but I was on a particular birth control, and I had been on this birth control for about a year and a half to 2 years at that point. And so I was just going in for a routine appointment with my gynecologist. She just happened one day to say, "Wait, do you suffer from migraines?" Now that had been in my chart from the beginning, because I'm very kind of working in the healthcare field, I know the importance of like writing down our medical history and all of that. So that had been in there from the beginning. And I said, yes. And she said, oh, this birth control actually should not be prescribed to women who suffer from migraines. And she said it could potentially lead to seizures and, and got me off of it fairly quickly, which, that was a whole thing in itself. But that just, I think what you just highlighted, I think is really important for everyone to realize the importance of for us to read charts, right, when clients write information down, but then also for clients and patients, sometimes they'll just, kind of go breeze through our intake forms and not
Right.
really write down, answer those questions as thoroughly. And I think maybe sometimes the thought is, oh, I'll just share that information when I'm sitting across from my therapist or sitting across from my doctor or whatnot. But then in the moment, sometimes we might get caught up in a conversation and forget to mention everything that we want to mention. And so that part I think is really important, is all the medications that we're on, because medications might not necessarily work with medications that we might be prescribed, right, from the doctor that we're sitting across from. So I think that's a great point that you just pointed out.
Right.
Mhm.
Yeah, absolutely. Just attention to the patient as a whole person, their physiology, other medical issues, other medicines, even personal habits. Someone who smokes makes their liver metabolize medicines quicker. Someone who drinks in the early stages, it quickens the metabolism of their liver. Their liver is busy metabolizing alcohol, so it's kind of overall working faster. So even subtle things like that.
So I have a small, just this, this is a Natalie question out of curiosity. So you mentioned Zoloft earlier, right? Which is you said an antidepressant. Why are some antidepressants sometimes used to treat anxiety? I'm just curious about that.
Right. Yeah. It's really, in the old days, over 30 years ago when I was being trained, at the time, it was the tricyclic antidepressants that were the mainstay of treating depression. So you had like Elavil, Amylor, Sinequan, Imipramine, Tofranil, and there's generic names, but those medicines were 70s, 80s, but they were dangerous because patients could overdose and die. And
Wow.
but we used those to treat panic disorder and excessive worrying. Then the serotonin medications came out. And the serotonin medications are Prozac, Paxil, Zoloft, Lexapro, Celexa, and Luvox. They're like essentially laser beams that go into the serotonin mood circuit neurons. They block a reuptake pump in which that serotonin neuron would recycle the chemical, the neurotransmitter serotonin. So it keeps serotonin out in the synapse, giving downstream stimulation. And what we found is that the serotonin SSRIs, selective serotonin uptake inhibitors, SSRIs, were very effective for panic disorder, generalized anxiety, and for OCD, obsessive compulsive disorder. And also I think for panic and worrying, GID, the SSRIs work quicker. So instead of being 2 to 6 weeks, I think it's like maybe 1 to 3 weeks. So wherever anxiety is occurring in the brain and serotonin plays a role, the serotonin medications can work faster. Now, that being said, I would say generally that when a person takes an SSRI for anxiety symptoms, they may get 50 to 75% relief. Generally speaking, some people are lucky, they get 100% relief. Some people only a little, 25%, but they're helpful, but they're not necessarily the complete solution for that person. Hopefully, they're seeing Natalie and Hannah
Yeah.
on a weekly basis to get help in their coping skills.
Yes.
Oh, that was really good. That was really helpful. I was
Yeah.
always curious about that.
hmm Yeah, that is very helpful. Well, another question that came up is, do psychiatric medications change your personality permanently? Which I've had that common question from clients.
Yes.
How do you define personality and personality change? And what I would say, it's almost like that when a person takes medication, it's almost like they get a biochemical tune-up so that their brain works better. and they feel more positive about life. They have more energy, more motivation. So there are like characteristics of personality that are better, improved, but the person's personality still stays the same. And, a person's personality is also somewhat affected by counseling, psychotherapy. So
Mhm.
it's almost like I use the metaphor of the person is driving a car on a trip, and the psychiatrist is a mechanic who tunes up the car to make it function the best. The engine's tuned up, the shock absorbers are changed for bumps along the road. The tires are better tires that grip the road. But then you, the psychotherapist, are the navigator, and you're training the patient how to drive to make the right choices during their journey. But the patient is still the patient. The patient is still the personality of the vehicle driving it, but there are enhancements. So I think that I've seen medications help people make major life changes because maybe it takes them out of a depressed state where they're just living in a terrible environment. Maybe they're being emotionally abused, and it helps enhance their mood, their self-esteem, where they can finally stop being a victim and they can confront the perpetrators in their life. Okay. Is that a personality change? I mean, how do you argue that? I mean, yeah, there's a difference, but it's also almost like an augmentation and improvement to the foundation of their personality. In the same way with you guys, how you work with your clients and you teach them how to communicate better, maybe not being aggressive or passive when they're facing some conflict or confrontation, but to be assertive, to be healthy, with their communication to get what they need, but yet not act out with a bunch of anger. So
Mhm.
I think all of mental health is kind of an augmentation and an enhancement and a tune up to the person's biological state, the physical state of their vehicle. And what you guys do, it kind of helps with the software and the decisions and the path they choose to take.
I love that analogy. And it reminds me of like family systems theory because once a client starts making changes in their own life, like they start setting boundaries and standing up for
Yeah,
themselves, it disturbs the whole system, like the whole family system, because they're making changes. So it
yeah,
sounds like that, they are changing, but it's for the better. It's to better themselves.
right. I
Mhm.
agree.
That's great.
Yeah,
That's really, yeah, I love that. It's funny because when this question came up, and then I also saw that it was a question that was asked, I wholeheartily agree, Hannah, that it's also come up for me multiple times in sessions with clients, and so I had a feeling that this would be a question that that we would touch upon, and the few times that the few times that I've addressed it, I've oftentimes asked the client, "Can you define like what exactly do you mean by personality?" Because and then as the conversation begins to kind of unravel, we kind of peel back the layers. I begin to realize that there's this fear here of really what they're talking about. It's just like feeling like they're no longer in control of like their like moods, like how they're feeling, like their moods or their attitudes or that kind of thing. And so that helps me better than understand what they're anticipating and what they're worried about or concerned about. And so we can go from like changes in personality to more so like, okay, so you're more so talking about feeling, you're worried about feeling these uncontrollable like changes in mood, and which then I think you highlighted a little earlier, Dr. Griffith, about just kind of side effects, right? And so I always encourage them then to talk to their providers about that, about the potential side effects of medications, what to look for, warning signs, and the importance of catching them early and communicating those concerns early with their provider and not waiting too long. And then also speaking to having some kind of loved one, whether it's a partner, like their spouse or a child, a friend, someone who they don't have to stand on the rooftop and announce to the world that they're on a medication if they don't want to, but at least have someone that knows that they're on a
right.
medication, who sees them on a fairly consistent basis, who can kind of gauge as an outsider if there's something that is changing but not for the better.
Right.
That can kind of say, hey, I think something's a little off. Are you sensing that something's off? And then we might need to make a sooner follow-up appointment with your provider. And so that's always the way I've kind of tackled that conversation, when it's come up in sessions with our clients. So what are your thoughts on that, Dr. Griffith?
I absolutely agree with what you're saying, to basically have a support system. And I like what you said, that if you have a loved one who loves you unconditionally at home, in your family, whatever, that's the type of person, but it may be as innocuous as saying, well, I'm just getting help,
Mm-hmm.
for some of the stress I'm dealing with. So yeah, I think get your support system, surround yourself with a good support system, develop a healthy support system, use it. Let your professional clinician be part of that support system to help do the higher level work and move you forward. Yeah. And you
Yeah.
guys, what you do, I mean, if you think about the vehicle on a journey, the patient, you really are the navigator.
Mm-hmm.
You're the one who looks at the map. You look at the journey historically, where they've been, how beat up their car's been from the journey in family life and growing up. And then it's like, now you have the rest of their life ahead of them. What choices do you want to make? You have to teach them, well, you decided to drive through the desert in these situations, and then you had flat tires and you ran out of gas and your radiator overheated. Let's stay on this highway for now. But they never got that growing up. They never had a
Mm-hmm.
navigator, and we all need a navigator, like what you all provide to your patients and clients.
I love that. I feel like you're describing my vehicle and how I treat my vehicle. I
Oh.
I think that I love that analogy. I meant to say that earlier just because, I think it's recently over the last few years that we've really begun to, I say we, but just like providers in adjacent industries have really begun to realize the significance and importance of working together and coordinating care and just communicating with each other. I mean, you play a significant role. We play a significant role. Our patients slash clients play an absolute significant role in their journey. And we all kind of need to be communicating with each other in order to be able to provide them, the best experience possible. So I really, really do love that. Love that analogy. So I feel like it would probably be best to maybe kind of end with this question, because I know every person's journey is very individualized, but the pros and cons on average with like taking medication, psychiatric medication. So what are some of the benefits, some of the pros, and then what would you say are some of the potential cons, or so maybe like side effects would be listed under that category. What comes to mind?
Yeah, so I think you have to look at one patient who is having an acute crisis, and then you have to look at another patient who is in like a chronic crisis. And so the acute crisis patient, let's just say they for some reason ran into unforeseen financial problems, relationship problems, employment problems, or just some unexpected thing. And it's such a big stressor that they're not sleeping, they can't function, they're anxious all the time, they've lost all hope. And you have to kind of get them through this crisis, and sometimes you use medications to help them sleep, to help them not have panic attacks. And it's like you look at their journey beforehand, before this crisis, and they had a great vehicle and they had a great road trip, everything, the car worked great, they worked great, but then boom, like bandits hijacked them right at a road stop, something like that. And so you get them through this crisis temporarily with medication. You send them to a Hannah or a Natalie to get some software help, decision making, working through these tears, this anger, this anxiety. And then, you guys would probably be involved a little bit longer than me, but hey, you don't need your Xanax anymore. We use this Zoloft just for a temporary time period because of this crisis. Live happily ever after. I'm available if you need me in the future. Okay, so, and then the cons of that, medication wise, is that, okay, if I give them Ambien for sleep or Xanax for daytime anxiety, I don't want them to overuse it and get habituated to it, to depend upon it. I want them to develop coping skills and overcome stress rather than pop another Xanax. And then I have to make sure that I get them off the medication in a friendly fashion, because sometimes when you stop a Zoloft immediately, you can go through withdrawal like nausea, dizziness, people call them brain zaps, and you just feel anxious and not like yourself. So that would be some of the cons. But those people, you get them through the crisis and they kind of live happily ever after. Then you have the chronic patients, and these are patients with genetic issues, bad hardware. So this would be person who, I mean, they could be like college educated, very successful, happily married, great personality, but they have bad genes for depression. And you look at their family tree, and maybe they have three family members who committed suicide, like great uncles and grandparents, or maybe everyone was abusing alcohol or drugs because they were self medicating. That type of person, you kind of have to say, look, you've got great software. You have good decision making, you love yourself, but your hardware genetically is the root of the problem. So you kind of educate them. We need to use a more chronic approach to medication long term. This would be similar to a person with diabetes, juvenile
Mm-hmm.
diabetes or high cholesterol. It's just familial, or
Mm-hmm.
hypertension, and things like that. It's like, okay, let's find the friendliest combination of one medication, multiple medications that are needed to help you overcome the genetic hardship that you've been dealt, and function, at the best of your capacity. And so I don't want to give them a medication that makes them overly tired. I don't want to give them a medication that makes them gain 50 pounds. I don't want to, like, lithium is a great medication for bipolar disorder, but if it's used at high doses chronically, it's going to basically fry the kidneys. So when I use lithium, I try to make it very low dose and short term because it'll stress out the kidneys. But yet there's some patients where they've tried every bipolar med in the universe, and lithium is the only one that works, and at high doses. These are like two different scenarios of medication. The pros are you use medication to tune up that engine to get them through the acute stressor temporarily, and they can use their navigator and themselves to navigate life thereafter off of meds. And then you have the chronic, and the pros are the medication can help them function normally, and they just have a bad vehicle, a bad engine. And the cons are trying to find the right medications that don't stress out or harm their body, and to try to keep them away from getting, quote unquote, emotionally habituated or addicted to the ones that have addictive properties, like Xanax.
Mm-hmm.
So,
Yeah. I really like the two differences because that's actually kind of how I like your analogies better. But I explain it to my clients kind of like that. Like sometimes you just need it short term, but there's other people who will need it more lifelong because their genetics are just
right.
trash, basically. And I'm one of those people. And I feel like you described it well. Like I have great coping skills. I go to my therapist. I have a very peaceful life, but genetically it sucks. So
You're hardwired.
yeah.
Yeah. But you know what? You are obviously optimizing the performance of your vehicle, because look at your current journey. You
Yeah.
know, it's
Yeah.
it's it's pretty smooth sailing. It's good.
Hmm.
Yeah.
Yeah, this is
Yeah.
really good. It was a great conversation. As always, I feel like we can go on and on. I mean, I'm thinking already like two or three questions that I could potentially ask. I love that. I love our conversations. This was
Me
really
too.
great. So, yeah, Dr. Griffith, if anybody's interested in finding you, as we always kind of end our videos, where can people find you?
Well, they can Google me, Walter Griffith, MD. The name of our practice is Dr. TMS Therapy, actually .com, online, and Griffith Psychiatry. So, we have offices in St. Petersburg, Countryside, North Clearwater, and then the third office is down at Lakewood Ranch in the Sarasota area. And yeah, we love treating our patients, and we're an outpatient practice. We provide transcranial magnetic stimulation therapy, which is really superior to antidepressant medication in many ways. It's more effective and it's more user friendly. But yeah, I can be found online.
Yeah, thank you so much. Thank you again for your time. And hopefully, you guys enjoyed this conversation. If you have any other questions or any other ideas for future videos, feel free to put your comments below. And as always, keep reflecting.